Dr. Pontone, one of the things that I'd love to start with is a little bit of talk about apathy. What can people do? I'm sure you're going to say this is more of an issue for maybe a care partner or somebody who's dealing with somebody who has Parkinson's, but what can the person with Parkinson's do? What can a care partner do? What is going on, really?
Yeah, so that's a great point. So apathy and complaints of apathy usually don't come from the patient or the person suffering from it. In fact, they don't care. That's part of the apathy. It's usually a family member, spouse, or caregiver who comes to us and says, they're literally doing nothing. They don't initiate anything. That's the main problem with apathy. And so apathy is probably part cognitive problem, that failure to initiate. And so the most effective intervention really is to provide a structured day or routine for the person suffering from apathy so that they can have that additional support. Because one of the things you'll find is, although they might lack initiative to start things on their own, they can participate when guided. And so that's probably the most important thing. There are some medication trials, those acetylcholinesterase inhibitors like rivastigmine, donepezil that I mentioned. Those have shown some efficacy and might be helpful. But really, it's about providing the opportunity to engage in activities.
Okay, great. Thank you very much. Dr. Tarolli, so you talked about the mild and severe cases of cognitive decline and that kind of thing. Is if somebody is feeling sort of mild cognitive issues, is it normal? Can that mild stage last for a really long time, or is it going to progress, or can somebody really just sort of be in that mild stage forever?
Dr. Pontone, do you want to take that, Greg? I don't know, because you talked a little about cognition. I don't know if you want to take that one.
Absolutely, yeah. So one of the things that I think we're learning is that there's different trajectories in terms of how cognition will progress or stabilize in Parkinson's. And so sometimes the domain that's first affected, for instance, people who have memory domain or visual spatial dysfunction early tend to have a little more problem long term, whereas people who have that executive dysfunction can sort of stay right there and not progress significantly for a long time and continue to function well and make adjustments. And so I think the difference is that there's apples and oranges. It really depends on the individual and the type of problem they're having early. And so I think regardless, the best thing you can do is all the things we talked about, staying active, staying social, exercising until, we sort the science out so that we can better predict who might need a particular treatment compared to someone else right now. And so what I would say is, if you're noticing early memory problems, early language problems, that's certainly something that you want to bring to your doctor right away so that they can start doing these things, because that's one of the predictors maybe that you're going to go on from the mild to the more aggressive form of the cognitive changes.
Okay, great, thank you. Dr. Tarolli, is there, does weather, someone asked if weather aggravated NOH, is it also common for it to be, a real problem in the morning, but to get better, in the afternoon?
Yes, those are good questions. I don't know of any clear association between weather and orthostatic hypotension. I will say, if it's warmer outside and you're sweating more and you're losing more fluid, you're probably more likely to potentially have some effects of orthostatic hypotension, because again, you don't have as much fluid in your bloodstream. But again, I don't know of a clear association with that. The second was about time of day. I will say for many patients, they will notice that it is worse in the morning, and that's because their body has essentially equilibrated. It's gotten used to being in that flat position, and it's really easy when our body is in that flat position for our heart to pump as much blood as it needs to get to the brain. Whereas when we stand up, your body has to fight against gravity to get the blood up to the brain. And so because that transition happens so early in the day where you've been asleep, lying down for a number of hours, and then you wake up, that's a big transition. And so many patients do describe that it's worse in the mornings, yes.
Okay. So this is going to kind of be for Dr. Tarolli and David. So people frequently ask about pain with exercise. So part of this is complicated, right? Because they may have pain related to something else. They may have orthopedic pain. They may have arthritis, or they may have Parkinson's pain. And we tell them to exercise, and the pain kind of keeps them from exercising. If we can get them to exercise, they might feel better, but then the pain is still there. So can you talk a little bit about that in terms of helping people understand when is pain too much, when should they stop, and when they can keep going? And then David, I'd love to talk about how dance can actually minimize some of that.
Yeah, so this is a great question, and it's kind of, as I said, this can end up being a catch-22. You know, patients don't feel good, they have a lot of pain, they don't want to move. And if that's the case, if people find that whatever type of exercise that they are doing is making them too uncomfortable to move, that's really where I rely on other therapists. So things like dance, things like boxing, physical therapists, where they can actually work with some of these folks who are real experts in movement and can actually give patients specific graded exercises where they can introduce things very slowly back into their regimen so that it can actually get them to be moving. Because what we know is no matter the underlying cause of pain, the vast majority of pain is going to be better if patients are able to remain active. It's just finding what that activity is going to be. And again, I often end up relying on my colleagues, in physical therapy, dance, all of these other activity areas to really give us a sense of that. And then I'll just very briefly mention, in terms of what patients should know about their own limitations, this is really something that you need to explore yourself. I never want somebody to push themselves to the point that they feel uncomfortable, because one of the most important things I say to my patients about exercise is that the exercise that you should be doing is the exercise that you will do. If I told you that biking or walking or running or something else or boxing or dancing is the best thing and you hate doing those or those make you feel uncomfortable, you're not going to do it. And so that's why I encourage everybody to find the exercise that really works for them and that they feel comfortable doing.
Right, thank you.
And then I'll pass it off to David for his comments because I think they'll be really useful.
Thanks, Dr. Tarolli. Yeah, I would agree with that. I think finding the thing that you love and that your body wants to do, that your body finds delicious, you're gonna get more of a reward doing those things. And in that reward situation, you're actually you're more likely to get into a flow state. When athletes and dancers talk about getting into a sense of flow, where you have this single focus on what you're doing, you're not distracted by anything else, and you can really be attuned to your physical experience in that setting. And then it really only works if you're doing something that is meaningful to you and is enjoyable to you. So whether that's dance or boxing or yoga, find that thing. And I think you may find that pain is reduced because you're able to get into that state of flow. Also, all of these activities are working on countering rigidity. And it's, as Dr. Tarolli said earlier, rigidity is one of those things that can actually cause pain. So as long as you're working in a modality that has a gradual entry process. In other words, in dance, we use something called a progressive warm-up, which means we start really slowly, we start quietly, we start with smaller movements, we start to grow the complexity and intensity of that movement over the course of 45 minutes to an hour. So you're not jumping right in and doing big movements that could cause pain. We're really allowing you to find your comfort level as you move up. And as things get more complex at any time, you can find a plateau and say, you know what, I'm not going to push myself more. This is where I'm comfortable. Or not experiencing pain, I'm going to go a little bit more. And any modality that has that, I mean, we do it especially in dance because that's how dance training is at any level. But you'll see that also in yoga, in other forms of movement. If you can find something that has a progressive warm-up in it, that's going to be a place where you can really better gauge your level of comfort particularly in regards to pain. And I would say balance as well is another one where you really want to be regulating yourself and attuning to what's comfortable for you as you go along.
Great. And I think you brought up a great point. So, and this is true definitely outside of COVID, but during COVID, even more so, I think, is that you all get to decide, right? So if you have this progressive warm up, you might just sit in a chair, right? You might just sit in a chair, but the act of showing up in that way is actually really beneficial. So if you're watching other people doing it, you're connecting with the community, even if it's online. If you're around people and they're moving next to you, there's value in that. So if you've been somebody who's a little maybe hesitant to try it out, there's no such thing as doing it wrong. You can do it the level that feels comfortable for you. People ask about yoga, Tai Chi, fabulous things to do for people with Parkinson's. There is a lot of actual evidence on Tai Chi about it being beneficial. So if that's available to you, I highly encourage it for sure.
And those are both forms, again, that use that progression, right? You're not jumping right into high intensity activity. You are gradually going in. I'll just dovetail, Mel, what you're saying. There's actually quite a lot of research on what's called action observation in cognitive neuroscience, which is basically observing physical activity that your brain recognizes. And in essence, your brain actually goes through those movements as you're watching it, even if you yourself are not moving physically. So there is cognitive benefit to watching movement that you're not fully participating in. Of course, you're not getting the same physical benefits, but there's still something going on. So try not to judge yourself or get down on yourself if you are sitting out an activity or simply being there to participate. You're still getting that stimulation.
Great, that's a great point. Dr. Pontone, so somebody's asking, and this is a question we get fairly often about, is there neurocognitive testing to determine if you're competent enough to keep working? Also driving, there are people that are asking all of these different things of like, how do I know if it's too much? And I think for care partners, especially wanting to know, like, how can they help out in those areas?
That's a great question. And so I'm going to give you the typical scenario. When you go to see your doctor, most of us will give some sort of in-office screening test. Right now, one of the best screening tests is the Montreal Cognitive Assessment, because it really does a pretty good job of screening the executive domain in Parkinson's, but it also touches on a lot of those other cognitive domains like visual, spatial, memory, attention that I mentioned. And so, if you fall outside of the normal range, that would trigger a more sophisticated battery, of tests that would, in a much more sensitive way, look at each of those individual domains. And that type of testing can take half a day. And so that would be by referral if there was a signal on that screening test. Now, the other really important way that this comes to our attention is because the patient or their spouse or caregiver notices dysfunction at home, a change in their ability to complete their daily tasks. And frankly, sometimes this is more important because everybody has a different baseline, and just falling outside of the norm doesn't necessarily mean that the disease has caused it. Some of us have just been working around deficits our whole life, and we've been effective, right? And maybe you're gifted in one domain and not so much in another, but you figured it out. And so I think at the end of the day, really it's a collaboration between the patient, their caregiver, and the providers that they're working with. And things like driving, everybody with Parkinson's has the same standard that everybody without Parkinson's has, right? They still need to pass that test from the MVA. So we recommend that you get tested there, or there's occupational therapists who have a simulation that takes into account additional features, like attention that might not necessarily show up on an individual driving test, but could still represent a risk. And so, great questions. And I would say err on the side of caution if you think you're doing something that might be unsafe due to these changes.
Great, thank you. Dr. Tarolli, can you talk a little bit about urination and very, very frequent urination with urgency that came up a couple times today? And also, I was talking to somebody, a care partner this week who, their wife is in a wheelchair, and the biggest issue is the going to the bathroom all the time. And there's no break. Is there medication? Is there anything proven to help? What can people do?
Yeah. Yeah, so again, another great question. I will just again mention that this is probably one of the areas where I feel less comfortable, but I'll tell you what I talk to my patients about. So what we know about urination in Parkinson's is that, again, this is part of our autonomic nervous system that allows us to urinate appropriately. And what we see in Parkinson's is that sometimes people can have difficulty emptying their bladder. They can have difficulty getting all of the urine out of your bladder. And if that happens, that can cause irritation in the bladder, can potentially predispose somebody to things like urinary tract infections, and can potentially cause things like urinary urgency or frequency, meaning you're urinating quite a bit. There are medications that we can use to help treat that. For men especially, we need to make sure that there's not any other contributing cause, things like an enlarged prostate, which can certainly cause increased frequency or urgency of urination. But if that's not the case, then we do have medications that actually relax the bladder a little bit and can help to reduce some of those frequency and urges. I'll be honest, once I get past those first-line medications, I end up relying on my urology colleagues to help me with managing these, but we do definitely have medication and other strategies that we can use. The other things that I commonly recommend to patients is just making sure that they're regularly emptying their bladder, having scheduled emptying, you know, even if it means going into the bathroom and emptying as much as you can once an hour or once every 2 hours. That can sometimes be helpful to reduce the discomfort that comes along with this and the potential for things like infection that can come along with it.
Great, thanks. A few people have asked about massage therapy. Some people have said it helps them a lot. If it helps you a lot, I would say keep it up. As you're probably, you know, if you're at a trained massage therapist, they're not going to do any damage. They're, you know, if they're trained and, you know, well licensed, then and it feels good, even if it is temporary. It's a great thing. So somebody is asking about anesthesia. And first of all, in general, what is it for people with Parkinson's? Is that a concern? And then second of all, after anesthesia, is it typical for Parkinson's symptoms, especially motor symptoms, to be more acute? Does anybody have that answer or know about that?
I can talk a little bit about anesthesia and its effects on Parkinson's. So one of the things we know is that we want to do our best to minimize anesthesia. We know that patients with Parkinson's are more likely to have more pronounced confusion and pronounced and prolonged side effects and symptoms following anesthesia. And patients with Parkinson's are less likely to tolerate anesthesia. So we actually have some fairly standard language that we provide to surgeons whenever one of our patients is undergoing surgery, ways to try to minimize the amount of anesthesia that those patients are getting in order to reduce those side effects as much as we can. I don't think we probably have enough of a understanding of exactly why that is, but it certainly is probably related to the fact that there is a process, a pathologic process going on in the brain, and people who have pathological processes in their brain are going to naturally take longer to recover when you use something like an anesthetic. So again, really working with surgeons and anesthesiologists to reduce the anesthesia administration as much as we can. And actually, for anyone who's familiar with the brain stimulation surgery, many of you probably know that we often do these surgeries awake. And there's a couple reasons from a logistical standpoint that we do those surgeries awake, but part of that is also reducing the total amount of anesthetic burden in that setting.
Great, thank you. Somebody's asked if there are a list of urologists who have an understanding of patients with PD. I'm not sure, but what I would do is I would actually talk to your movement disorder specialist, or your neurologist is probably going to have the best info about that for people in your local area. Yes. Okay. So there were a couple of questions about smell and swallowing. Is smell a symptom of or lack of smell? Is that a common symptom of people with Parkinson's? And swallowing, like what's really going on to make that a challenge for people with Parkinson's, or what are some things they can do? I would say, you know, besides working maybe with a speech and language pathologist, what's really happening there?
Sure, I can take at least part of these ones. So the loss of sense of smell, extremely common. I mentioned during my talk that non-motor symptoms can start before Parkinson's, and one of the places we actually think Parkinson's starts in our nervous system is actually tracking up through the nerves that allow us to smell in our nose. So we know that there is early degeneration, early loss of those cells in the setting of Parkinson's. And actually, when we go back and ask people who are diagnosed with Parkinson's, many will say that for the past 2, 3, 5, maybe even up to 10 years, before they had any motor symptoms, they will have noticed that their sense of smell, and often associated with that, their sense of taste has gone down. So yes, definitely a part of the disease, probably early portion of the pathological process. Regarding swallowing, I think different people probably characterize this in different ways. The way that I think about it is really it's a progression of the motor symptom. So you can imagine with the motor symptoms that we have, you have things like difficulty with coordinating movements, with those with slowing of movement, and problems with actually coordinating some of those more complex motor activities. Well, the reality is our esophagus, our pharynx, our larynx, those are all just muscles also, and they can be affected as the disease progresses as well. And so the way that I very broadly think about that is that it is part of the motor dysfunction that is part of the disease progression. We do typically see it, but usually pretty late in the disease course, though again, this is something that I'm often screening for in my office visits, asking if patients have difficulty with swallowing, particularly with liquids, which is the more, slightly more concerning form of swallowing difficulties. I don't know, Dr. Pontone, if you have any other thoughts on that.
No, I think those are all great points. And I mean, really though, although there's sophisticated tests to sort of evaluate these once they're identified, the identification really happens by the patient, their caregivers, and family paying attention, because that's how they come to our awareness. For instance, we'll hear, hey, he's really sort of coughing and choking when he's, sipping water or something, and then that sort of triggers the next step in the process. But that's really what gets you through the door. And so, we really need to establish this collaboration, not only with the patient, but with their family and caregivers. And that's why I said this is really a group activity.
Great. Dr. Pontone, can you actually talk a little bit about, you just mentioned it real briefly, about visual spatial issues in Parkinson's?
Yeah, so one of the things that can happen is that your actual perception, the vision itself, although that can change with Parkinson's, but the way your brain processes that input can be disordered or dysfunctional. And when that happens, you might have trouble judging distances between objects. So for instance, if you're walking, you might misjudge things, and so that can contribute to falls. The other way we see it show up in more advanced cases is becoming disoriented within your environment, even a familiar environment. And like I said, for most people, that could represent a more aggressive trajectory of cognitive change. And so if that starts to happen, that's one of those things where rather than trying to work around it or whatnot initially, you want to bring that to your physician's awareness, because oftentimes that might trigger us to start a medication earlier than, if you're just having the executive dysfunction that's ubiquitous in the Parkinson's.
Okay, thank you. A couple of people have asked about ED or sexual dysfunction. What role does that play for people with Parkinson's? And can anything be done about it? And what are sort of some of the expectations that people might be facing with that?
So this falls within that category of autonomic symptoms in Parkinson's, kind of the dysregulation of those involuntary portions of our nervous system. Erectile dysfunction, very common in the general population, though when we look at patients with Parkinson's in comparison, people with Parkinson's are probably about 2 times as likely to have erectile dysfunction as opposed to someone who does not have it, who's the same age and has the same underlying diagnoses. This is one of those areas where there really has not been a lot of research dedicated to the treatment of this in the setting of Parkinson's. The first thing, though, that we need to do anytime someone is being seen with erectile dysfunction is make sure we're ruling out secondary causes. Sometimes medications can have side effects of erectile dysfunction, not usually the anti-Parkinson's medications, but antidepressants very commonly do have that. And similarly, there are a number of other medications. There can also be a lot of social factors that are related to this, and so we also want to make sure that we're identifying those and helping people to work through those things. Again, if we don't identify any underlying secondary cause, that's when we start thinking about the use of medications, and the use here is going to be the same as would be in any other person who has erectile dysfunction. Again, taking into account other conditions that you may have that might make it less safe for you to use medications like that. I will just say, I think we get often asked about erectile dysfunction. I will say female sexual dysfunction is also quite common in Parkinson's, and unfortunately, there's not only not been a lot of work on the side of what to do in the setting of Parkinson's, but in reality, there hasn't been a lot of work on what to do in the setting of female dysfunction generally. So there are, I often end up relying on my urology or maybe OBGYN colleagues in that setting, but I just want to also be clear that it's not just male sexual dysfunction, but also female sexual dysfunction that can happen in these settings.
Okay, great. So one of the questions we get often is that from people that say, like, I don't want to take medication for my Parkinson's at all. And we do know that the medication will help with symptoms. But they want to know, is it helping with the progression? Meaning, if somebody just doesn't take medication, what is happening to their Parkinson's? And is it, oh gosh, like by the time I get to start taking medication, it's progressed so far that I can't do anything? Or is it just you're going to live with the sort of pain and the trouble and the burden of all those symptoms until you're willing to take it?
Yeah, I don't, Chris, I'll certainly let you chime in here, but we have a pretty strong opinion about that. And I think the science backs this up, is that the current medications that replace dopamine don't alter disease course. They are not disease modifying. They are symptomatic medications. And so the guidance right now is that you take a sufficient amount of those symptomatic medications to have the highest quality of life possible right now. And in fact, you could even make the argument that if you're functioning well now and able to be vigorous and exercise, that really indirectly it is sort of helping you have a better overall course indirectly. And so, I think there's one other study that really supports this. And so, people often wonder, if I take the medications now, am I using up this window of time when they're most effective, or am I hastening the onset of the motor complications, things like dyskinesia, on-off fluctuations? And it turns out that they've done a study of people who didn't have access to dopamine and those who did. And even these people who had a delayed start to their dopamine, they still developed motor complications in that same time frame from disease onset. The paper is by Cilia et al. And it's really interesting. So that means that the time of disease duration, more than the exposure to the dopamine medications, is what's determining the development of these complications. So really, all you're missing out on is the best function you can have. So we strongly recommend that you start medications as soon as your symptoms interfere with your ability to live the way you want to.
Right. Would you add anything to that, Dr. Tarolli?
I fully and wholeheartedly second literally everything he just said. I mean, I think that is such an important concept, that as soon as your symptoms are affecting your quality of life, your motor symptoms specifically, you should be really strongly thinking about going on medications. I very strongly encourage people to do that.
Great. So someone asked, if you start Levodopa, can you stop?
Sure. I mean, again, as Dr. Pontone mentioned, this is what we call a symptomatic medication, meaning it treats the symptoms and, again, can be quite effective at treating many of the symptoms of Parkinson's, but it's not modifying the course of the disease. And so if, for whatever reason, side effects, personal desire, whatever that reason is, someone feels like they don't want to be on the levodopa anymore, they're not doing direct harm to themselves. Again, though, I really talk with folks about why they want to come off of the medication, because, again, we want to make sure that we're maintaining their motor function as best we can with that.
Yeah, absolutely. Dr. Pontone, somebody's asking if sleep disorder is an indicator of the risk of more cognitive decline. Are those linked?
So we think so. So REM sleep behavior disorder is certainly something that's a prodromal symptom for not just Parkinson's disease, but many alpha-synucleinopathies, including dementia with Lewy bodies. And so it's certainly been linked to related dementing disorders. And exactly what that link is in terms of the pathology or the mechanism, we're not sure. But I can tell you that from the time I started my career till now, we know much, much more. And I think we are absolutely on a path to recognize this disease earlier and either slow it down or ideally stop it. I mean, this is one of the most exciting times in my career. I mean, we are on the edge of disease modifying treatments. We're going to change the face of this thing.
That is exciting. So I think I know the answer to this one. Probably it's an indirect relationship, but can levodopa help with non-motor symptoms?
Yeah, so that's a great question. The answer is yes, it can. But in general, it does not. So I guess that's the kind of very broad answer. The way that I qualify that is there are some non-motor symptoms that clearly worsen in the states where patients have their medications wearing off. So for example, I have some patients who clearly have anxiety that is worse in their off state. I have patients who clearly have pain, right? I mentioned that as a non-motor symptom, but the pain is secondary to some of their motor symptoms, so worse when they're in the off state also. So it can be. The way that I talk with folks about the likelihood of their symptoms, their non-motor symptoms responding to medication, though, is how well that correlates to their on time when their medications are working versus their off time when they're not working. If it's a symptom that's there no matter where they stand in terms of their medication status, then it's much less likely that levodopa is going to help with that, and we should be thinking about alternative strategies.
Great. And also, would it be true or correct in saying that, so if you're taking levodopa, the goal then is for you to have more on time. And if you're having more on time, you're feeling better, then you're going to exercise, then you're going to get out, then you're going to connect, then you're going to do all of those things that indirectly are actually what helps with the non-motor symptoms of maybe depression and anxiety and all of that kind of stuff. So I think there are a couple of different ways. And one of the ways that why everybody says taking the medication is good, you want your best possible performance, and that means feeling well enough to do the things that are actually going to make you feel better. So a couple of people have asked about things related to swallowing, some things more I think that are better for like physical therapists, speech language pathologists to talk about, and I can send, for those of you, if your questions were not answered directly here, I will send links to some of the, because we do have some of those answers from people that have sent things in about this topic. I don't want to get too in the weeds in terms of certain medication dosages because everybody is so different and they might be taking other medications. And so the doctors here couldn't possibly answer those unless they really know more about you. So I'm going to hold off on those. Let's see. David, there have been studies on the benefits of doing the tango and Irish step dancing. Does it make that much difference what type of dancing you do regarding PD? David, I would love for you to answer this question because of another question that we recently got about somebody with ballroom dancing. So let's finish with this question. I think it's super interesting and I'd love to hear your response.
Sure, great question. There are now more than 40 peer-reviewed studies on the impact of dance and Parkinson's. And included in that are studies on Argentine tango, Irish set dancing, which is the form of dancing that uses a formation of 8 people, 4 couples, doing quite quick footwork and patterns. That's where most of the research has been, and also dance for PD. All of these studies point to, preliminarily at least, potential benefits on both the motor and non-motor side, and we're very happy to see that. In terms of one dance form over the other, it really depends, again, on what you like to do and also the level of complexity. Irish set dancing, for example, has a lot of complex patterning and quite quick foot movements. For some people, that would be very welcome. For others, it would be prohibitively difficult, and they wouldn't do it. Same with Argentine Tango, which, depending on how it's done and how it's taught, can work a lot on functional mobility and balance, and that's really what the research picked up on. But for some people, can be very challenging. It's a challenging form to learn. It really has to be done with a partner, so it's not applicable for everybody, especially right now. And then Dance for PD has had a number of studies done on motor skills, particularly on gait, stride length, and gait consistency, also on tremor, on facial expression, and some quality of life things. So there's good research supporting this. I'll put a link up to some of that. But there hasn't really been good comparative studies. And honestly, I believe that all dance shares a DNA where those core, a neuroscientist would call these movement primitives, these elements of dance, like weight shift, focus on balance, rhythm, swing, change of direction, walking forwards and backwards, the thing that a physical therapist would emphasize in a session. All of those things are incorporated in all of these forms. They're there just by nature of the way that dance is structured. So you can't really go wrong in any of them. Where you can go wrong is being forced into a form that you don't like, and that doesn't feel right or appropriate for your level. And so I would encourage you to find the form that you really like, the style you really like, a teacher you really like, and go with that, because you'll be getting the same basic benefits in whatever form you choose. And I will post a link to some more research so you can read a bit more in depth on that.
Great. Thank you. Well, thank you, everybody, for being here. Dr. Tarolli, Dr. Pontone, David, thank you so much for staying for this panel. I know the Q&A is super, people love it. They don't get enough time with their doctor, so they really want to be able to ask you guys questions. So I really appreciate you being here, and we'll look forward to seeing you again. So thank you.
Thanks so much.